All right, today we are going to have a short, quick conversation about DIC, disseminated intravascular coagulation. So, this is not a disease, but rather a sign of underlying disease. But we talk about it here because it is a bleeding disorder. Severity is variable, but there's a huge risk for mortality with this. So, from a nursing perspective, it's really important that we monitor signs and symptoms of this in patients who are at risk so that we can pick up on it early, and treat the underlying cause to prevent this from becoming a much bigger issue. So, triggers may include sepsis. We see a lot of this in the intensive care units, trauma, shock, cancer, abruptoplacental, those are our OB patient, specific toxins and allergic reactions, as well as can go on to lead to DIC. Most typically, we see it though in those first three: sepsis, trauma, and shock. So sick patients to begin with then go on to develop this bleeding issue. What actually happens is this trauma sends our body into a reactive state that causes massive microthrombi. So we get all these tiny little clots around in microcirculation. And as those clots continue to happen, we use up all of the clotting factors and then bleeding occurs. So first we get symptoms that are related to tissue ischemia because of all the little tiny clots, and then we get this massive bleeding. They start bleeding from really every orifice. So we're going to look at laboratory tests in a few slides, and you can really see then what lab test would we look at that would indicate the patient was suffering from this. But usually we first are going to see either symptoms of the clots or symptoms of the bleeding if this is already late stage. Treatment, the number one thing we need to do is treat the underlying cause. So if it's sepsis, give antibiotics. If it's trauma, treat it, give blood products, help, correct the issue. Then treatment of signs and symptoms of this. So correcting tissue ischemia, replacing fluids and electrolytes, maintaining blood pressure, replacing coagulation factors. So if we get to the point where they're in the bleeding stages of this, then we want to give them clotting factors because that's why they're bleeding. They have a lack of clotting factors. If it's in the beginning stages where they're still having all these little microthrombi, we can actually use heparin to prevent the clotting, thereby preventing the usage of all of those clotting factors so they don't get to the bleeding stage of this. Let's look at this here. Maybe this will help us to have a better visualization of the pathophysiology of DIC. So at the top there, we see this significant illness, sepsis, trauma, certain malignancies, complications from pregnancy, all those things we talked about. Down on one side, it says pathological activation of coagulation and impaired fibrinolysis. Say that 10 times fast. That leads to this thrombus formation and microcirculation. Down the left side of that, consumption of platelets and clotting factors leads ultimately to bleeding. The right side of it, we get the tissue ischemia, end organ damage, end organ failure related to the actual clots. So the clots are doing two things. They're leading to tissue ischemia and end organ damage, as well as they're consuming up all the clotting factors, which then leads to bleeding. As well as on the other side of that top box, we have activation of abnormal activation of our clotting that leads to further bleeding. So there's really kind of two things going on here. What do we from a nursing perspective want to do? We want to be aware of patients who are at risk for this, like I already said on that first slide. We want to catch this early. If we catch this early when the patients still have available clotting factors, we will prevent progression of this to bleeding. And the bleeding literally is massive. It occurs from every orifice, mucous membranes, everywhere there's a tube, everywhere there's a drain, every system begins to bleed. Of course, then that is going to progress to multi-organ system failure or multi-organ dysfunction syndrome. We pick up on this early, we treat it with heparin. We pick up on it later, we treat it with coagulation factors, as well as replacement of those factors and giving them blood and fluids to maintain perfusion and oxygenation. Because of course, it's a lack of oxygenation to tissues, which is leading to end organ damage. So here's a box that kind of shows us the common lab values associated with DIC. Platelet counts, of course, are going to be low in the latter stages of DIC. As those microthrombi are forming, we're using up platelets and clotting factors. As that progresses, we're going to see platelet counts go down. That platelet counts going down is what ultimately is going to lead the patient to bleeding. We see PT, APTT, those are indicators of clotting going up, which means that what? It's taking longer for the patient to clot. And so those, of course, are going to be seen as well as the disease, or not a disease really, it's a symptom of disease. So as this occurs, we're going to see those go up. The fibrinogen, the amount available for coagulation, so as this progresses, we're going to see that go down because we have less clotting factors. D-dimer is going to go up because that's going to show us that there is these little clots occurring. So we're going to see that elevation in the beginning. And you don't need to know these values. You don't need to know what each of them mean. You should understand that the platelet count here will be low. That's what's going to lead them to bleed, and their PT and APTTs are going to be up. Those are the basic kind of things that we need to know about DIC in terms of lab values. So what nursing diagnoses are these patients really at risk for? Risk for fluid volume deficit. That's bleeding, right? Lack of volume. Risk for impaired skin integrity. They're going to be bleeding. They're going to be sick. They're going to be in the unit. They're going to be vented. Risk for imbalanced fluid volume. That goes right to that bleeding and fluid volume deficit. Ineffective tissue perfusion. Not only because of the microthrombi that are occurring early in the symptoms of this, but the bleeding that then occurs later, which leads to decreased volume and decreased perfusion to organs. Death anxiety. These are the patients who are knocking on death's door, per se. They are very, very sick. We need to be very, very cognizant of their care. We need to be educating them, family members, about how sick they are and treating their anxiety as well. What are we going to do? I think we already said most of these things. The number one thing you're going to do is correct the cause. That's what's going to treat the DIC in and of itself. While we're correcting the cause and waiting for antibiotics to help with a patient who's septic, for example, we can do things like vent them to improve oxygenation. We can give blood products. We can give fluids to maintain blood pressure. We can give cryoprecipitate, which is a blood product that's full of factor VIII, clotting factors. We can give fresh frozen plasma that's full of clotting factors to help them clot and prevent the bleeding from progressing to ultimately death. These patients can just bleed and bleed and bleed and bleed, and there's nothing we can do about it, and that's ultimately how they die. So just some pharmacological considerations is unfractionated heparin or low molecular weight heparin therapy, which is Lovenox, can be given early in symptoms of this. That's what stops the microthrombi from forming and eating up all of those clotting factors that ultimately lead to the bleeding. So if we catch it early, we can give some of these anticoagulants to help. Once they're bleeding, we probably aren't going to give these because the clotting factors are already eaten up. So there's a time and a place for giving anticoagulants in this disease progression. Once they're bleeding, probably not the best time. We need to fix the cause and give them clotting factors to help them stop acutely bleeding.